Is that going to take too long? We want to start solving solutions now, and we know what the problem is, so we want to start working towards it, but we do need to hear, and that's what Caroline is going to tell us about.
Thank you very much. Thank you for asking me to come and talk. I thought just to start with a little bit of data. So across England and Wales, somebody is dying every minute. There are 57 deaths an hour. So in this 3-hour meeting that we have today, that's going to be 200 people who will have died in that time across the country. And in 2040, that number will rise per hour to 72 because of the rising demographics. And at the moment, we think that about 75% of people who die require palliative care because 25% of people get killed in a car crash or die very early or die of a heart attack or something like that. What we know is from the demographics that number, that percentage is going to rise to about 86% of all deaths. So we have and what we've done in London over the last 5 years, we have reduced the in-hospital death rate by about 0.5% per year over the last 3 years. So we are bringing that down very, very slowly. And as Penny has said, many people do need to die in hospital. But you can see that there is a maths problem going on here. And with the rising number of people who are dying, unless we do something radical to change where people are cared for and to start these conversations, which you've all agreed about, we're going to have a problem with hospital bed numbers. So we have to do something radically. And I was at the Houses of Parliament talking about that only yesterday morning, really trying to get across that there is a sort of a mathematical challenge which we have to face very, very seriously. And I think, actually it can only be done if we do some radical stuff and we really work well together. Okay, so what you all know, oh no, I didn't see which one to fill. Is it this one? Yeah, you all know about Barnet. You know all about North Central London. This is where the hospitals are. We've got 2 hospices there. We have a population of 1.5 million. We've got lots of ethnic diversity with 25% of people for whom English is not their own language. We've got lots of deprivation and inequality, so we can go from sublime wealth to abject poverty through each borough, and we need to be very sensitive to that. We've got lots of homelessness and temporary housing, particularly in the southern areas. There is an NHS deficit across the STP. We've got quite a lot of hospitals, and we've got some hospitals, particularly in the south of the borough, which are cheek by jowl. And depending on the day of the week, patients can fancy going to this hospital or that hospital. I live between 2 hospitals, and depending what's wrong with me or my family, I go to one or the other. That is not helpful in Cornwall, or when you're more rural, you have one hospital and all the information is there. So the proximity and the complexity both of people and the health and social care providers in London makes the provision of care very complicated, I would say. So, what are we looking for? I think you very much articulated what we all want for people who are dying. Most of us in the room will have experienced somebody we know and love coming to the end of their life, and we all know in our heart how that experience was, whether we had time to say the things we wanted to say, whether the care was given with utter compassion, whether that person had been recognised that our loved one was coming to the end of their life, whether we were informed, whether we were able to inform our siblings, our loved ones, and whether they had really excellent care. And I don't mean standard care, we mean excellent care, and that's what we are aspiring for, and I'm sure you are. We can't settle for sort of second, moderate best, I would say. We all know whether information was repeated to us or to our loved one and the message was the same, or whether it was changed, and the nuance and how confusing that can be if it's not a similar sort of message. And we also know whether we were cared for when we were grieving. We all know that, and we know whether that was compassionate or not. We know how our bosses treated us and all the rest of it. So that's, I think, what we are looking for, and for us to deliver that as staff, we need confidence and we need skills to recognise and do something with that gut feeling which says, uh-oh, this person looks worse. I'm worried about them. I think they might be coming to the end of their life. Not tomorrow, in some time. The last time I saw them in clinic, they looked like this, or in the surgery. We need access to experts. That's not just palliative care experts. It's people like Penny, it's surgeons, it's other people, it's ambulance clinicians, it's GPs, it's district nurses, it's pharmacists. We are all experts, but we need access to the right expert to care for our patients and their families. We have to have facilities to care for people in line with their wishes, and we need that information exactly as has been described. So we're not aiming for anything easy, or but that's what we need to be going for. So what do we know about North Central London across the STP? We know how many people die each year, so died last year, about 7,500. And therefore, if you take 75% of those requiring end-of-life care in Barnet, 1,800. We have 2,400 deaths in the borough last year, and we should be able to recognise about 1,800 of those. So I would question, are we doing that? Are we finding those people? And what are we doing with them? We also know how we've been doing with where people die. Barnet is the green line. The red line is the percentage of deaths in hospital in London over the last 6 years. The blue line is the English average, and these are the 5 boroughs across NCL and the percentage of what percentage of people die in hospital. So we are bringing that percentage down, but it isn't over speedy, and you can see some variation between the boroughs. And why is that? One of the things, as Penny alluded to, is that some people do need to be in hospital. But actually, one of the metrics that we have been thinking about at a national level to measure good end-of-life care is the percentage of people who go into hospital 3 or more times in the last 3 months of their life. Because actually somebody needs to be saying, hang on a second, and to go in 3 times in your last 3 months of life. Many of you may have experienced that with your own loved ones or with patients. It's pretty traumatic, and it's, as Penny has alluded to, it's quite undignified. And the plan is from 2018-19, that will be the national metric for end-of-life care. So we're trying to recognise that dying in hospital might be right, but going into hospital in an ambulance 3 times in the last 3 months of life is not right. And I think we all know that. So this is the baseline data which we have, which is old, and we are going to be, by April, we will be able to see the trend. It's from 2015. This is the London-wide metric, and here are we in North Central London. And this is the blue line across the middle is the English average. So you can see that across London there is quite significant variation depending on where you live and in the percentage of people who are admitted 3 or more times in emergency. So we've got a bit of a way to go, I would say. We know we have been mapping the sort of end-of-life care is not just specialist palliative care, it's district nursing, it's pharmacy, it's allied health profession, it's care home working, it's a single point of access, access to fast track, access to equipment. We've been mapping how that is across each of the boroughs, and there is quite a significant difference.